Good. Good afternoon, everybody, or good morning for some of you. Thank you for coming to this review session. We are going to show you the slides of the circulation, but then Simona has collected some really interesting cases, and at the end we'll show you some our I'm sorry you can leave early. We are really grateful to Sarah and the team for putting this together, and to Karen Parish and the team at Stellas for sponsoring this. So I'm going to pin these and go to the first case, which is this one here. No, it's right? This one here. No, beforehand, Simona wants to say a few words here. Yeah.
Our colleague Hannah prepared this pie chart, which I think is very interesting to notice how many of the people that participated in this feedback session are reporting frequently CLDN18. And you can see it's quite a small number, only almost 15%, while half of the participants are infrequently. Quite a good number, they're in training, and another 16, even more, they have no experience, even more than the ones frequently have no experience at all with this biomarker. So I think it's quite interesting to see, because I think also the results will reflect a little bit this.
Yeah,
this proportion.
And it's early days, this is really only just started. So there are very few centers that have some experience in this. Okay, so that's the first case. We got lots of columns, but I think the column, so we asked you very kindly to put the results in bins, in 25% kind of bins. And we wanted to make a little bit of make some attention to those results that are around the threshold, which, as you know, is 75%. So thank you for doing this, although eventually it will be just a positive, negative, 75 or less than 75%. And I think we probably should look at this column here, which are those of you who are used to CLDN report frequently. And so for this case, there was a split between 0 to 25 or 25 to 50%, but in any case, this was a negative case because the threshold is here at the 75%. And for all this work, you have also a panel diagnosis, which says also more or less the same as this as internal. And then Simona knows what to do here, which I think is
not the right. Yeah.
This one.
And is this case? First case, yes.
Okay, take it away.
If I remember how to deal with this one. Okay, so low power, it's an endoscopic biopsy, probably gastro-esophageal junction. We see here some squamous epithelium, and then we are hunting for our invasive carcinoma. We need to make sure that as much as possible, we can tell apart which it is invasive and which bit is high-grade dysplasia or even low-grade dysplasia, so that these plastic bits.
Yeah. So sorry to interrupt. So in fact, at our session during the ECP, this was perhaps the emerging concern was in this small endoscopic biopsy. Sometimes it's really, really difficult to identify the targets of our quantification. And Simona presented some nice cases where at first glance, a case would be negative or positive, but then when you look very carefully, you understand that the invasive carcinoma is a much smaller amount, and therefore the diagnosis changes. So in fact, what we discussed in Vienna was that this is much more difficult to report on small biopsies than, let's say, breast cancer for HER2-low or something like this. In breast cancer, it's almost always very easy to identify.
It's warm here. Feels like home. Feels like home. Just for you.
Okay. So it's always there is an invasive carcinoma in things like breast, for instance, or even lung. But in gastric, small superficial biopsy, this is a big challenge. Okay, so Simona.
And I think how we were looking before here, that this bit we can call, and we are happy to call it, invasive carcinoma. Here as well.
Yeah.
But I don't know about this part here. Would you think this is still invasive carcinoma, or do you think it is high-grade dysplasia?
So these are well-formed glands, are going to be near the surface. They look very different from the polydifferentiated invasive that you showed before. And unfortunately, gastric carcinoma can have a multitude of different patterns in the same biopsy. So these are all the difficulties.
Yes.
This
I think is quite challenging a little bit. And you can see also the intestinal metaplasia wise here with all this.
I mean, I would say I would have high suspicion that perhaps it's still intraepithelial.
This is quite a lot as well.
Yeah.
Here I think it's starting being a little bit more convincing.
Yeah.
And forming more architectural
and maybe a little bit here. But...
Yes.
Okay. So let's see, because sometimes when you look at the clothing, then everything is clear.
Yes.
You don't have to be, you don't have to worry too much. So
this
here,
clothing. We have the external control, but on slide.
Can you just show the external controls in? You mean on slide control?
On slide control.
So this is normal gastric mucosa. Yeah.
Yes.
And it's always a good idea to include it because your biopsy may or may not have it, and also it serves you as a reference from slide to slide. Okay. So would you say at low power, these high expressors, what are they at low power? There are areas like this one here, they are very high expressors. What are they? Are they invasive carcinoma, you think?
Well, that's a good question because we noticed here and here that was a little bit the same architectural, quite contortious glands. And I think if we are calling everything invasive, let's go to the most awful approach. Everything is invasive.
Yeah.
And we are scoring everything that is staining.
Yeah.
Even if this is invasive with strong intensity, we can see clotting here quite strong. These bits, they are more weak intensity, so I wouldn't score it. We need to have moderate or strong membrane staining. So overall, on low magnification, this for me would be a negative.
So what you're saying, at low power, if we thought that everything is invasive carcinoma, at low power, we don't go above the magic 75%.
Yes.
Because you remember that we need to score strong staining intensity and moderate staining intensity. Remember the chocolates. And so anything that at this power doesn't show up very well is probably going to be not scoreable.
Yes, or weak intensity.
So the downside of this approach is, as we discussed a little bit earlier, is that not all of this could be invasive carcinoma. In fact, there will be biopsies where the majority of it is not invasive carcinoma, and then you'll find a tiny little corner where there is invasive carcinoma, and that is all positive. So that's why you need to kind of labor a lot more.
But then here, where we were quite sure that this portion was invasive, it's negative.
Okay. All right. So if we go back to our PowerPoint, which said, it's either up to 25% or maybe above 25%, or not much more. I think we would think this was that.
And from my point of view, it is a case where it is around the 25%. Either it's 30 or it's a 20.
Perfect.
It's around that.
Okay, so percentage. Sarah will keep an eye on the chat, but you can tell us. We may even be able to open chats. Oh, there you go. Okay.
Okay. What percentage do you give it? Do you give? Okay. I was reading also the message above.
Okay. What would you score this as? Do you think 25% this case? I would say maybe a bit less than 25% because I suspect that this very strong staining, it actually is not invasive carcinoma. So there are occasional single cells. So me, I would score it, I would put it in the bin 0 to 25%. Thinking about 5% of this kind of thing, 10% of this kind of that's not.
That's not even.
Yeah, this is either macrophage staining, but I don't think it is. This is rubbish staining.
Exactly. So this we shouldn't even score it. Yes, I tend to agree with you. I might give exactly 25. So then I will go into the above category.
Yeah. Okay.
And then we have another comment. According to the package insert, tissue with intestinal metaplasia should be used as on-slide control, but have normal gastric mucosa. Can you elaborate on why you made that decision?
Certainly. So, this is our piece of stomach, gastric. So this is not metaplastic. So gastric mucosa stains intensely, but we know that I don't think you should generalize, but usually small intestinal metaplasia has a less intense staining intensity.
It can be weak or moderate or even absent at all.
So obviously, and you know that because we discussed this on slide control a lot, it would pay off to put varying tissue where there is varying staining intensity. So it would be great to have a piece of stomach with a bit of intestinal metaplasia, a bit of negative staining and a bit of strong staining. So you have all the staining intensity. There is no rule. The pitfall of using something like what we use today here is that even if the analytical performance drops a little bit, we are likely to still see strong staining intensity because this is maximized. Instead, if this was a moderate or weak staining, normally we would notice that drop in staining intensity if the assay performance.
We are happy if you want to interact with us, but if not, it's okay. You can also put it in the chat. Probably
yes, absolutely. If you want to unmute and make comments, please do, or otherwise use the chat. Fantastic. Shall we go to case 2?
Yes.
There's something else. Just a moment.
Okay. I cannot. Okay. Roche guide only handles positive and negative with a 75 cutoff point. Yes.
Yes. That's that currently currently patients eligible for the drug or not eligible for the drug are selected on a 75% cutoff rate. This may stay with us forever or may change. Yeah. We thought that as an exercise, this is the first circulation we do, and to understand a little bit better how difficult or how easy these cases are and the constraint is, we thought we would put bins so that we can understand, because we can all be right to say everything is negative below 75%, but I think it's 2% and you think it's 70%. Yeah. It will still be.
We wanted to get a sense also how people will put in these categories, and also for the participants to realize how far or close they are with the consensus.
The majority.
Yeah. Exactly.
So, by the way, if you go to CLDN18.com, is a website where there is quite a lot of information and quite interesting and supporting all
and it's the abbreviation from Claudine. So
fantastic. Okay. We pass on case 2. Again, this is a case where, again, looking at the middle column here.
Quite split, I would say.
A little bit, yes. There is a bit of a difference. Is it just below the threshold? Is just above the threshold?
Yes.
Here, the consensus, but it's not the majority.
No.
So thought this was positive, but some of us thought it was in fact below the threshold.
Well,
so this is case 15. Case 15 will be
should be immediately after.
Very good. Oh, it's a large biopsy. No, what is this? It's a metastasis.
I think it is a metastasis, how it looks like. And it's our favorite type of metastasis where you have poorly differentiated signet ring cells, most probably. Yes, can you go a little bit here? Because probably we're going to see them a little bit better. Or not. Look, single cells spread. Yes, these are the challenging
And the
cases.
background here is mostly connective tissue cells and inflammatory cells.
Probably.
So the tumor load is not huge. Or it may be big.
You don't know.
We don't know. Okay, so
most useful trick here, it is to a pancytokeratin. And it's going to show you the load very nicely, and then you can compare it with the Claudin, and then you will see exactly how many are staining and how many are not staining.
This would be tumor.
Yes.
Have you done a pancytokeratin?
Maybe we have done it on the
real case.
The real case, but I don't think we put at the.
We should have taken the slides with us. Okay, but that's a good suggestion. You know, now you start to see a little bit more, but the tumor load is low. Okay, let's see if by any chance these are all positive cells, which are also going to help us identification. That's the same control. Not holding my breath very much here. There we are.
Look at these. And look how many are they more than we would have thought when you look at the.
So question for you. Am I going to assume that all the cells here staining are definitely tumor cells, or can these antibodies stain connective tissue cells?
It shouldn't. It should not stain connective tissue. If it does, then we have a problem of pre-analytics or with the antibody, but.
Okay, so to be honest with you, there is a lot more tumor than I thought there was at the beginning, which means
but look, this one now you can see that these are tumor cells and they are not staining.
Not all staining.
Okay. So we can understand that probably this is around the threshold of positivity. Now the question is, are we make it above or under?
So I mean. Given that it is a difficult case and opinion was split, I feel that the only real way of
moving forward
would be to do a pancytokeratin
and to compare it to see exactly how many cells you have, how it looks, and compared with the H&E.
Of course, the most purist among us will say, this is an anathema. You should be able to recognize tumor cells on morphology. Well, maybe you're right, but. I don't know.
This is challenging.
It's challenging. So, I kind of sympathize for those for the participant that said less than 75%.
No, I would be
it's just
more than this, but not more. I would be cautious indeed. I would say just above 75, and especially again, it's about context. I would think.
So the other thing I wanted to ask you is some of these slides are not rendering very well. Okay, but here it is. So the other thing I want to ask you, there is a lot of staining, but a lot of it seems to be cytoplasm. So for instance, a cell like that, is there really membrane staining here?
No, that's no.
And therefore,
you're already almost times 40.
Yeah, so. And therefore I have an extra preoccupation. My extra preoccupation is that although I see a lot of brown, not all of it is a positive cell. So, the more I look at this, the more I think maybe I would go with the minority that said less than 70%, 75%. Clearly here you see good demonstration.
Yes.
This would be perhaps a moderate staining intensity. So again, all good in terms of staining. This is also good. But there are other areas where maybe because there is crash artifact, I don't know, where there is also cytoplasmic staining. I mean, would you think there is membrane staining here?
No. That one I wouldn't score it.
Yeah. So
but the one above, yes, I would score it.
So kind of interesting case. I feel we let our friends down by not showing them a pancytokeratin. We'll endure next time to bring it with us. But as you can see here, some membrane staining, but some is clearly not membrane staining.
It is plastic. So unless you see clear cut of a membrane staining, we should not score the cytoplasmic.
Okay, let's see if anybody wants to post some comments over these things, but this is, I think, a fairly difficult case. We have comments, Sarah? No, no comments. Too difficult for everybody. Okay, so...
But more than 85, the people that said more than 85, I think you should, yes.
I think we are not in a strong position to make any definitive...
Yeah, to convince them. That's good, because on the next clothing session that we will go back and we're going to show you this case again with a pan-cytokeratin.
Okay, so this is the third case, and this one seems to be a more obvious positive case.
But interesting when you look at the other column of infrequent and in training.
Yes, most people identify that there is staining. Let's have a look. So this is 23. And incidentally, most 23, most of the time you will find that your diagnosis will be pretty straightforward, either positive or negative. This looks like a polydifferentiated tumor. Trying to make some attempt at making glands, but not managing entirely well. So this is all tumor. This is all tumor. This is a bit taken out of the tissue. Who knows? This is very kind of
crushed.
Has lost its identity. So I don't know whether we could score it or not. This one is a bit better differentiated.
The mucinous.
Would any of these be in situ?
I don't think so. No. I think it's quite clearly this is almost all invasive. And one thing that I would pay attention always on the H&E is identify your areas of necrosis, because those areas usually are staining, and they are staining completely black. And when you look at your clothing, you think on low power, oh, it's all black, it's good, there is staining. And always, for example, in this situation, I wouldn't score anything of this bit, because what is staining is the, not even stroma, is the
proteinaceous, proteinaceous debris that are around it.
Because this was the tissue with very squashed and with a lot of necrosis. So be aware of this.
And also these ones, although it's tempting to say, but they're clearly positive cells, but if they're dissociated, they could have been stripped off from the mucosa. So again, be selective. You don't need to worry about these things. This is a very, very good demonstration. Here you see weaker staining, but this is necrosis, isn't it?
Exactly.
Yes.
So keep in mind what you've seen on the H&E, where you have the areas of necrosis, compare it with the H&E. And when you see staining on clothing, as any other biomarker, make sure what type of staining it is. And in this case, we need membrane staining, moderate or strong intensity. And we need to make sure that that is membrane and not cytoplasmic or anything else.
So we had an interesting discussion at ECP about whether you need a linear or a lateral or basolateral staining, or whether you need only a small amount of it. And if you look at the interpretation guide, and you realize that you only even need a tiny amount of staining, potentially even just a dot. So I was kind of looking at these things and I was thinking which cells would be negative. This cell here, I mean, it's sharing the side with a cell that is really positive, but maybe this is not this bit of membrane, but we don't know. So there is always this dilemma also whether to allow. Yes. And we were talking with one of our colleagues from the States. I'm very sorry, the name I forgot. And she was telling me that, oh no, she thinks that in an example such as that, this cell is not positive, even though the borders with something that is staining she would score this as negative. So there is always some personalized interpretation, and nobody knows what's the reality. So in terms of staining intensity, would you call this moderate or would you call it weak?
I would call weak. But weak, this bit here. This for me is weak. This bit, I think I would go towards moderate.
Okay.
So yes, because look, even on very low power, you can still see that membrane.
But as I said, normally the cases will be relatively easy to score. The individual cell present positive or negative will not make a difference on the total normally. Okay, so we go back
I think that
to
this was more of a straightforward case.
Okay. Number 4, this was a clear-cut negative case, so maybe we don't even have to see it. Define.
I was about to say, oh, look, it's all positive, but I think that's all control.
Yes. Okay, so
squashed.
A bit squashed. A bit squashed. And again, I think you need to exercise a lot of caution when you score these biomarkers on traumatic artifact tissue,
But again, here I think everything is invasive, looks invasive, it's quite...
There isn't an awful lot of tumor.
No.
The denominator here is very small.
And again, be aware of this when you have very little amount of tumor and you're starting having some staining. Those cases, I found them quite tricky because can jump into positive. 75 is not quite a low threshold, it's quite high. So, but my brain goes also into the PD-L1s and everything. When you have low amount of tumors, you need to be, any staining counts, and you need to bear that in mind.
Okay, so minimum number of cells that we would accept would
For
be
Claudine is 50.
50.
Yes.
Born out of extensive research into the area.
Well,
no, it's an empirical finding. Okay.
Always say, if it's positive, call it positive. If it's negative, take it with a pinch of salt, and maybe you should consider calling indeterminate and repeat on a larger sample if available.
Okay, so here we see this granular cytoplasmic staining.
Yes.
Potentially these are tumor cells, most likely.
Yeah.
This may be an area of artifact, I don't know, but maybe,
I would say
maybe there
membrane,
is
but
membrane
that's
staining here.
weak intensity. So it's
intensity, so negative.
It's not part of positive.
And this is really the only one that's staining. So you can see there is a little bit of staining here, but this will be weak staining, and also I'm sure if it's membrane staining. So this is where you can actually afford to do the scoring. So once you understand denominator, you can afford to do the scoring at relatively low power. You don't have to go to extra high power, as we've seen for HER2 ultra low.
Yes, indeed. And here was negative.
So if you have biomarkers to report for your diagnostic routine, pick up the Claudine and leave the HER2 ultra low in the tray for your
colleagues. This case, and because we are not going to show you all the cases that we've done also in Vienna, this case, I will make it as an example that if you have just this case on your slide, you should not call it negative. This case should be called indeterminate because you do not know if your antibody worked or not. You don't have an internal control on internal control, nothing was positive. So you have no idea if your antibody actually worked unless you have an on-slide control as here. And you can clearly see it's positive.
So this is why it's a good idea to put always a non-slide control so that you know that.
Because some biopsies, even if they are from gastro-esophageal junction, you do not have normal gastric mucosa over there, and you have just bits of squamous epithelium. So, or even from the gastric, if you have only tumor in the biopsy, then again you do not have.
And the tumor is negative.
Tumor is negative, then you never know.
You don't know whether it worked or not.
Indeterminate if you don't have a positive control.
It looks as if most people veer towards positive, but some people found a little bit of difficulty, so maybe it's a little bit borderline. Case 30. It's 30, 30, 30, this one here. Very good. A usual abundance of bites, of endoscopic bites, which gives a higher chance of having sufficient material. This looks all invasive carcinoma, no?
Yes, yes.
And oops, something happened. Sorry,
You went very high power, but in the wrong
I was
field.
touching the wrong part of the keypad. Okay, so this is all invasive.
It's a lot. And this is, again, I don't see any gastric mucosa. You have esophageal epithelium, but I don't see any normal.
Okay.
And it's really nice example.
And a low power is very hopeful. Squamous epithelium doesn't stain. No, it's very hopeful.
Oh, it shouldn't.
It should stain. Okay.
It shouldn't stain.
And we are now at ×3, ×5. Yeah, there it is. We can clearly see membrane staining. So we would classify this as strong membrane staining.
And moderate.
And moderate where you, this area here.
Yeah, exactly. And even here at the periphery.
Okay, so, the magnification rule, you can still use it. Now we're ×10, this would be moderate. If you see lines, that's good enough. Here, I'm not so sure I see lines. So I put a ×20. There are lines, but this is maybe weak staining.
Yes, going into weak. Now, you have a biopsy, so I don't think you can always blame the pre-analytics, but with biopsies, we shouldn't have that much of.
So we are back to, okay.
So this one where we had all the signet ring cells and everything, we could see that we had strong membrane staining, moderate, a little bit of weak membrane staining. Overall, taking everything together, I think everyone, and we can see also in the percentages, people were happy to score it more than 85.
Okay, so
more than 75, but even more than 85, I would think here.
Okay, perfect.
I don't know if I would give 100, to be honest, but still above the threshold and in the category of more than 85.
Okay, our friend Beppe Vialli would say nothing is 100%.
Nothing is.
Yeah,
probably he is right.
Okay, so we move on to the last case, and then perhaps you can show some of your other cases. Yeah. So this one, case number 6, I think most people thought this was negative. There must be a little bit of staining because they put them in the box of around more than 25, around 25%.
Again, probably they've been around the 25.
Okay, so this is case
threshold.
32.
Lovely. Oh, it is some staining.
There's a lot of staining. Do you think we need to see? Do you think we need to see?
This kind of staining, for me, it makes me wonder, is this intestinal metaplasia or not?
Yeah.
And it looks like.
Okay, so
now where is our
my
tumor?
hope was that this was there was an easy biopsy. I could see positive staining in it, but this is normal. So there is a lot of rubbish here. So we need the H&E really. Can't work without the H&E. What do we know? Okay, so mucinous lakes.
Floating some glands, cytological atypia, but still.
So this is a mucinous carcinoma.
Yeah, it is.
Could have been a breast biopsy.
That would have been nice.
But it's not. Okay, and then not sure what these things are. Very difficult to know these islands.
Let's look at the bit that was positive.
This is the gastric mucosa.
And with intestinal metaplasia as well.
Yeah.
So be aware of this. Some biopsies can be intensely positive, and then when we zoom in, everything it's normal mucosa or intestinal metaplasia.
So this one is high-grade dysplasia?
I would go into that part, yes.
Yeah. Okay.
Compared to the invasive
so we are going to focus on the mucinous areas for evaluation. Fantastic. And the mucinous areas show It paints the mucinous material,
Yes,
but
but not
hardly the cells. So the cells are staining, but it's very difficult to demonstrate
very
membrane staining
yes.
here. So, and it would be
But that gland over there that you have strong and even, no, that's mucin.
this one.
Yes.
But
So if this was the gland that is floating inside the mucin, and it is the invasive, that is scorable.
Some of it is
that is strong intensity and moderate intensity, some weak, some even none.
There were more here.
There were more here.
And again, you have the occasional cell with membrane staining, but a lot of it is this granular cytoplasmic or even extracellular
And
staining.
again, you are at almost 40
Yes.
intensity.
Never go to 40, sorry.
Never go to 40. Not with Claudine, at least.
Yeah.
Claudine is not for 40.
But again, you know, one or two cells that may be staining,
they are.
questionable membrane, very questionable membrane. Okay, so this is not a case, you know, the more we look at it, this is not a case that is going to make any arguments for positive results.
On the other
This
fragment.
is the other fragment here.
Yeah. Because look here. Here again, you had
that's
some.
nice.
Yeah, you had some staining. So that's why people probably scored
about a quarter of the tumor cells. Yeah.
And I would agree. For me, this would be around the 15, 20, depends how, like you said, the denominator of your report, how much do you have over there? How many cells do you have over there?
Excellent.
Oof.
So Simona has got
how many
a few cases, and you can choose you. So we have 15 minutes, 10 minutes to choose 2 or 3 cases, you know, these
Or
cases.
3 cases. This was my proof of concept one that I had very nicely. It was a poorly differentiated carcinoma, even a diffuse one. And here to demonstrate more this, they are starting to be more a little bit discohesive now and then, but still forming a little bit of clusters. And this, I was very happy to ask you, what stain do you think this is on immunohistochemistry?
And I said there are 2, but I was wrong.
But you were wrong, yes, because I didn't give you any clues.
Yeah.
But this was Icadere.
Yes.
And then
so
the brother of Icadere or the sister, how do you prefer?
Beta-catenin.
Exactly. So here we were happy to call it the carcinoma being in the group of epithelial to mesenchymal transformation.
Yeah.
And again, the proof of concept was that we have treatment for the patients that are HER2 positive. We have treatment for the ones that are PD-L1 positive. But what are we doing with the patients that are HER2 negative, PD-L1 negative, and also they have this aggressive diffuse cancer, and usually it's more to
younger people.
Exactly, to the younger people.
And now it usually presents advanced, etc.
In advanced stages.
And you see, this is it's interesting. This is very positive, and I'd like to understand now the distribution of Claudin positivity in adenocarcinoma, because the concept was that as you do not manage to assemble tight junctions, you expose Claudin, and therefore it becomes available for therapy. And so this would be the high responders.
Yes, indeed. And that's why probably the threshold is also quite high, 75. So this was a lucky case, as lucky as you can, case.
For the patient, you mean? If you want to call a patient with gastric carcinoma lucky.
Well, lucky in the end, because you have a treatment now.
Yeah.
While before, 3 years ago, you didn't have any treatment for these patients. So now at least you have zolbetuximab that they can be treated with.
Okay.
I think this case, I kind of showed you even last time.
Really nice cases.
Nice cases.
Super nice cases.
Super nice cases. Oof. Hold on. A super nice one. Look, this is a very...
That's an easy case.
That's an easy case, right?
No worries.
No worries. Very positive.
Yeah.
Again, here, remember, look what is positive. Go on high magnification to make sure these are tumor cells. And what you're seeing, it is staining, it is membrane staining. Always, always, always do that. And really nice cases. This one.
Okay.
This one was a little bit controversial, even at ECP.
A low power?
Low power.
Squamous epithelium.
Squamous epithelium.
I don't know, not invasive. Invasive,
No,
it's very
we don't know.
papillary.
And here, very hyperchromatic, dark. Here we're expecting something.
And it's interesting to see that the only thing that's staining is
this bit.
that fragment there. Okay.
So here, first one looks like this. And this is your Claudine.
So clearly positive.
Clearly positive for Claudine. But what is it?
But is it invasive?
That's the question that everyone asked. Is this invasive carcinoma? Is this a very well differentiated? You could say these are back-to-back. You could say these are quite starting to be architectural, quite distorted.
But is there any other area which is much more classically invasive carcinoma?
This more hyperchromatic one and looks poorly differentiated.
Yeah.
And our Claudine is completely negative, not even a sausage. So now what are we doing with this case?
Yeah.
Is this a collision, well differentiated and poorly differentiated? Regardless, if we are calling everything invasive, as you could see here on the H&E, it's not very clear here, but when we enter a little bit more in the block, a bigger piece appears and it's identical with this part, which is the poorly differentiated one.
Yeah.
So taking everything together, this might be under the threshold.
Yes.
It is under the threshold.
Eyeballing it is less than 50%. So if you consider everything invasive, it would be negative.
First, when we looked at it, we didn't think that is invasive carcinoma. We thought that is
this bit here.
This bit.
Yeah.
We thought it's more of a dysplasia-wise.
Okay, what if this biopsy contains two tumors?
Yes, or like this, a collision, yes.
And this is just a general discussion for people to think about. What do we do in case there are two distinct
If you can recognize clearly two different parts, big comment saying the poorly differentiated one is negative, the well-differentiated component, it is positive, mandatory if there is an excision, repeat on excision, and you can see the proportions.
And if there is no excision, you throw the ball to the oncologist and say, I don't know, that's what it is. So, there is no guidance in terms of how do we handle cases which have heterogeneous expression because of different components. And there could be collisions as said, or in this case, some people may take the view, no, there is only one invasive carcinoma, is the polydifferentiated one. So in reality, it doesn't matter what this case is. It's just to give us a moment to reflect that we need to resolve a little bit some of these questions that have been resolved in other systems, because we were saying that if this was HER2 in, let's say, even gastric, but it doesn't matter, let's say in breast, and we have two tumors, one positive, one negative, the oncologist says, well, thank you very much, I'll treat it in any case. Doesn't matter if there's a negative bit.
Exactly.
So we don't average anything in breast. But okay.
I'll be curious if you have any comments. What is your opinion?
Yeah.
If you would score this as invasive or not, this case, I think it will be.
Okay, you have time for one more.
Oh, one more. Let me think. This one, whoever was present, even at the Claudine session, the theory part, I think I showed it, and everyone wanted to see this fragment, which I didn't show this fragment.
Okay, so now can you?
And now I will show you this fragment. So let's remind ourselves a little bit. We have this portion here.
Tiny, maybe could be invasive, I'm not so sure.
Good. And it looks like this, even higher power.
Maybe. So this is the interesting consideration. So clearly, if we have a biopsy like this, we would not hesitate to say this is invasive carcinoma.
This one?
Yeah, in a gastric biopsy, in a person with a gastric mass, a gastric ulcer, etc., you would say this is invasive carcinoma.
That's what I'm saying. Context matters, of course. When clinicians say there is a mass.
Yeah, but then doesn't mean that this is the
I skipped a little bit because this is how it looks like, yeah?
Yeah.
So you have this bit here.
Yeah.
Zoom. Okay, you can see here normal gastric.
Kind of, yeah. And
invasive. We are happy to call this invasive carcinoma. Yeah. So if you have this biopsy, you're signing out as invasive carcinoma, you're very happy with it. But then you receive for biomarkers, someone else.
Yeah.
You receive it. You didn't sign it. I signed up invasive. I was like, done. I'm done with it. Then you have the Claudin, and you can see this bit is completely negative. This poorly differentiated.
Yeah.
And then you have this part here, along with these two as well.
Yeah.
And as I showed, looks like this. So it doesn't look like the invasive one.
No.
And then you're asking yourself, is this invasive or is this high-grade dysplasia? And you have staining, even strong and moderate. And you will show the fragment that everyone wanted to see, which is this one. And you can see this like a triangle, beautiful triangle. It looks the same here as the one previously we've seen. And this is your Claudin with strong and moderate and weak.
But this one looks invasive to me.
Is this invasive? That's the 100 points question.
Well, you yes. I mean, you can see on the Claudin, you begin to see the individual cells spinning off.
But the individual cells are negative. They are weak positive.
Weak positive. But this staining helps me identify that there is a component that is no longer bound by the...
And it looks like this. So like you said, the tiny ones, they're even weak. But the big ones, you have even strong staining.
But this could be, the big ones
so you
could
have
still
this
be in situ.
Portion that is definitely invasive and it's negative. And you have these portions here and looks like this.
And in reality, this is likely to be just either an early invasive or just a high-grade dysplasia. Yeah.
And how are you scoring? And then it is exactly...
I will show to all the colleagues I know, and then I'll just write a big report.
Usually Claudin is quite straightforward. These are difficult cases that you're having one every, I don't know, depends how frequent you report Claudin.
And it's interesting because we were at another session of CLDN18 at ECP, and most of the cases were large resection cases.
Yes.
And obviously it's much easier to navigate large resection cases. There is some difficulties because you have a bigger area, and so where there is heterogeneity, you need to count well and understand the denominator, but you don't have as much trouble as we have here to say what's invasive, what's not invasive.
What is not invasive.
But I think our experience at the moment is that most of the cases for CLDN18 are small endoscopic biopsies. They're not
all of them almost, all metastatic.
And I think all metastatic, yes, we have something. Well, metastatic it's easy because if there is an epithelial cell,
that's the thing. Yes, indeed. But what I found difficult, it's exactly what we talked, and we had the metastatic one. Not necessarily the signet ring, but those one are the most, even the poorly differentiated ones that just goes and you cannot see the equivalent of the lobular carcinoma. That over there, I would advocate for do another immunohistochemistry, and it is going to save you.
Okay, so a question for you. If we have an ascites,
yes.
Can we do CLDN18?
Yes. Same as HER2? Yes.
HER2.
Yes. Probably it's going to be a little bit more difficult, I would say. It's the same as the HER2 in the matter of when the HER2, when we see some membrane staining, you would see, if it's weak to moderate, I think you would do it on D-dish. But with Claudin, I think it will be a little bit more tricky.
If we have, so there's a question. If we have two invasive different components, we cannot assess on excision. Would it not be reasonable to look at the higher grade component and emphasize the Claudin status? Yeah, because we are thinking that the high grade component kills, but we are not necessarily, we don't really know what that patient has. And sometimes low grade disease kills and high grade disease doesn't in the same mix. So, yeah, I think what Adelina has posted in the chat is consideration. I think we should all think about these circumstances, and the discussion at your tumor board will be probably educational, not only for everybody else, but also for yourself to try and find a balance in it. So to go back to liquid, if you want, ascites, you know, and you do your nice cell pellet and you have a block, etc. But do we know whether in the trials they used
No.
acetylene? No, so they only used biopsies.
No.
Yeah. So
Corrado, can I ask a question?
absolutely.
When you have a very intensely staining biopsy, where you are not sure that you can discriminate between membrane staining and cytoplasmic staining, what criteria would you use to be sure? Because if you take cases number 3 and number 5 of the assessment cases, you will see two quite different, very positive cases concerning staining, right?
Yep. So how do we negotiate that? It's a very good question. Let's have a look at 30. So we know that the moment you have a lot of protein, you start to see a very thick membrane that is also cytoplasmic. You have staining in the cytoplasm, and this was case 30. This is case 5. So you see here you have definitely cytoplasmic staining, but then you keep looking at it and you feel, well, kind of reassured that there is also membrane staining. There are lots of examples here, but I think the previous one was also
the magic word, convincing.
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 Yes, because you see, I mean, at the end of the day, you need to sign out this report.
Exactly.
You as a pathologist need to say, well, guys, I've been looking at these things for a very long time. Is this 23? Yeah. In my life, I had lots of experience. This thing looks like I can say is membrane staining. It's the same as HER2. There are some HER2 which are nuclear and cytoplasmic and membrane staining. Yeah, it is a little bit like that.
Look at this.
Yes. But we're not going to say, but this is just cytoplasmic staining. I'm not scoring it. Everybody will say, come on, Corrado, this is positive cell. Yeah.
Okay. But do you look for cells that clearly have only membrane staining just to be sure?
Well, I think so, because Eftelios, the thing is like you can see there is always a spread. But in areas like that, and these are cells with very little cytoplasm, but then in areas where you see, what I've seen quite a lot here. I think it's genuine membrane staining, and then a lot of these cells have an overpowering amount of staining also in the cytoplasm. I don't see why it shouldn't be the case, given that proteins are assembled there in any case. But then you kind of feel, well, overall, I feel as a pathologist, as you said, I'm convinced that's the case. Yes. Science rules interpretation, as you can see,
Sure.
If you had asked me this question 40 years ago, when I was a budding scientist, I would have been appalled that anybody would call something like this membrane staining, because it clearly was not membrane staining, it's staining the cytoplasm. What are you talking about? But yes. And I'm pretty sure then also it would be actually also educational to understand the feedback from the people that score the trials. How would they score these cases? Because really we want to try and to reproduce those assessments really at the end of the day. Yeah.
Good, thank you.
Good question. Very good, guys. So this is now almost the hour, and bring it to a close. The next circulation will be follower 1, P63, HER2. Oh, no, not HER2. Come on, give us something more exciting. HER2. Can we not do HER2, IHC, and DDH? So there you are. When can we do something exciting? Follower 1, when? In October, the folate receptor alpha. Very good. Okay. Yes, when? Oh, I would be very interested to attend. P16 and P53 as biomarkers rather than just diagnostic staining. Fantastic. Thank you all very much.
Thank
See
you.
you